to present his presentation on palpitation and breathlessness. We present a case. And with this presentation, we finish our presentation part and we will go for the question and answer session. If you do have any queries, please put it in our reply. Dr. Parvez, I will request
Honorable Chairperson, respected teachers and my dear colleague, Assalamu alaikum. Now with the permission of the Chairperson, I am going to present my case. Today our topic is a case of palpitation and breathlessness in a middle-aged female. Mrs. Rehana, 50 years female, hailing from Tarakanda, housewife, came with a history of palpitation for 6 months and shortness of breath for same duration. Patient was relatively well 6 months back. Then she developed palpitation, which was more marked for the last 10 days. Palpitation was sudden onset, intermittent, increased on exertion, and not associated with syncope. She also developed breathlessness for 6 months, which was more marked for last 6 days. Breathlessness also increased on exertion and relieved by taking rest. Breathlessness was associated with dry cough but not associated with seasonal and diurnal variation. There was no history of late night breathlessness or increased breathlessness on lying position. With the above complaint, she admitted into cardiology department of CBMCB for better management. She has no past history of hypertension, diabetes, or ischemic heart disease. Treatment history: she used to take some medication irregularly from local doctors, but she cannot mention the name. He came from a middle class family. No family history of any chronic or congenital disease. She is a mother of 2 children by cesarean section and her delivery was uneventful. She is immunized as per EPO schedule and he also taken 3 doses COVID vaccination. Personal history, nothing contributory. On general examination, body weight average, patient is ill looking, decubitation choice, blood pressure 110 by 70 mm of mercury, pulse 96 beat per minute, respiratory rate 30 breath per minute, JPP not raised, and neck pain not engulfed. There is no edema, anemia is absent, jaundice, cyanosis, clubbing was absent, lymph node loss and thyroid gland is not palpable. On cardiovascular system examination, pulse is 96 beat per minute, which is regular, normal in volume, and no radioradial and radiofemoral delay. Blood pressure 110 by 60 mm of mercury, JBP is not raised. On examination of the precordium, size and shape of the chest is normal, no visible cardiac impulse, no epigastric pulsation, and no scar mark is present. Normal precordial movement. On palpation, apex beat in the 5th intercostal space in the mid-clavicular line and it is tapping in nature. On auscultation, faster sound is loud. There is a mid-diastolic murmur at the apex which is variable intensity. That is, murmur varies with the position and respiration. Other system examination, respiratory system, normal breath sound, there is no added sound, and GIT system, no organomegaly, nervous system was normal and intact, and other system reveals no abnormality. So Miss Rehana Parvin, age 50 years, hailing from Tarakanda, Mymensingh, came with the history of palpitation for 6 months, which was more marked for the last 10 days. Palpitation was sudden onset, intermittent, increased on exertion, and not associated with syncope. She also developed dyspnea for 6 months, which was more marked for the last 6 days. Dyspnea also increased on exertion and relieved by taking rest. Breathlessness was associated with dry cough but not associated with seasonal and diurnal variation. Was no history of orthopnea or PND. On examination, blood pressure is 110 by 60 millimeter of mercury, pulse is 93 beats per minute, which is regular and normal in volume and character. On CBS examination, FS beat in the fifth intercostal space, mid-clavicular line, tapping in nature. On auscultation, heart sound was loud. There was a mid-diastolic murmur in the mitral area with variable intensity, that is, murmur varies with the position and respiration. Other system examination reveals no abnormality. So the provisional diagnosis. Proceed. So our provisional diagnosis was mitral stenosis, and differential diagnosis was left atrial myxoma, AST, and LA thrombus. ECG was with a normal limit. Chest X-ray was normal. CBC normal. Thyroid function test was normal. Serum creatinine normal, and pro-BNP was also normal. There is the ECG, which was normal, and this is the X-ray, which was also normal. Then we did the echocardiogram, and we found a large pedunculated mass in the left atrium attached to the interatrial septum. It was mobile, prolapsing into the mitral orifice during diastole. So our diagnosis was Sadequel LA myxoma. This is the picture. And this is another picture. So our final diagnosis was left atrial myxoma. Management, definite management is a surgical excision under cardiopulmonary bypass, and preoperatively we used furosemide and spironolactone combination, bisoprolol, propionate, and aspirin. Prognosis is good after surgical excision. So thank you for patience.